introduce her. Dr. Maki is a professor of psychiatry, psychology, and obstetrics and gynecology at the University of University of Illinois at Chicago. She is the past president of the North American Menopause Society and a member of the International Menopause Society. She has researched women's brains for 25 years and how menopause affects their brains. So she has a lot of information that she's going to impart with us that you maybe have never heard before, or maybe it's confirmation of things that you have heard. And finally, she has served as an advisor to both the president and the vice president. So she has a lot of credentials. She knows what she's talking about. She has a very vigorous program. I think there'll be time though for Q&A at the end. So, you know, or maybe during, would you prefer at the end or during? Okay.
Yeah.
So if you have a question, raise your hand and she'll call upon you.
Thank you.
So,
Susan.
thank you.
Thanks. Look at all of you showing up to learn about it. For you. I guess there's a lack of information out there, huh? If you have to slog through the rain and come to the Hinsdale Public Library to learn about menopause, right? So let's have a conversation about it. So all of my research is in self-interest. I'm just kidding. Because it's really hard to find information about menopause, isn't it? Right? So how many of you have gone to your OBGYN or primary care physician in the last year? How many of you in the back of your head had a question about something related to menopause or you weren't sure it was related to menopause? And how many of you got the answers that you wanted? Good for you. That's awesome. That's great. The minority of us, and in fact, that's what the research shows. And we're trying to change that, and we're going to change that a little bit tonight. So I'm going to give you kind of an overview on the basics of menopause. I'm going to talk about what happens to our bodies when we transition through menopause. I'm going to talk about the symptoms of menopause, how they relate to one another, and then I'm going to talk a little bit about the treatments that are evidence-based, and then you ask me questions. Okay, ask me any questions that you have on your mind, and I'll do my best to answer them. So this article, sorry, how many of you saw this article? Oh, this is on a timer of some kind. How many of you saw, sorry, there's a timer going. How many of you saw this article in the New York Times Magazine? Any of you see this article? It was a cover page of the New York Times. Okay, so this was the #1 gifted article in 2023.
Wow.
Of all of the news articles published in the New York Times in 2023, this was the one that was gifted the most. And I think that tells us why you're here tonight, because we need answers. And the idea here is women have been misled about menopause. The general idea is that we're told, just deal with it. Don't ask questions, suffer through it, just deal with it. And my goal today, and Susan Dominus's goal when she wrote that, is to say, nope, that's not what we're going to do. We're going to start asking questions and demanding answers. Most of us, when we have questions that are not answered by our physicians, go to what? Social media, our friends, and we ask questions. And if you, for example, how many of you have felt forgetful? Kind of worries you, and you think, oh my God, am I dementing? That's really common, and then you think about that grandmother or that relative who has dementia, right? And you're like, oh my God, and we're terrified of it, right? 2/3 of people with dementia are female. So we're right to be worried about it. You're not dementing. But let's say that you want to go and ask your provider about hormone therapy. And you've heard mixed messages. Oh, it causes dementia. It doesn't cause dementia. It's good for your brain. And you go on social media. Here's a sample of the contradictory information you're going to receive on social media. Like women who decide to take hormone therapy may be less likely to develop dementia because of their lifestyle and not because of their hormone therapy. Estrogen can protect the brain from damage due to Alzheimer's disease. Over-the-counter hormone replacement therapy, a dangerous step for a liberation. There is no clear answer out there. And so we need to do better for women, because when there's a lack of information, you get bombarded in Google. If you type in menopause, what do you see? Supplements, products, home test for what phase of menopause am I in, right? Because people are making a lot of money on menopause. And menopause, we know what to do about it. It's just women's providers don't know what to do about it. So what doctors don't know about menopause? How many hours of training do you think physicians have in menopause? Just guess. Shout it out. 2, 0, 5. How many women go through it? All of us. If you had a sexually transmitted disease, would they know how to fix it? Yes. What percent would? 100%. 80% of graduating residents say they feel barely comfortable talking about menopause, because they get less than 1 hour of training. And that's what we're trying to do. We're trying to affect change. Why? Because 84% of women say their menopause symptoms interfere with their life. So there's this mismatch between the questions that women have and the ability of their providers to tell them what they need to know. What are the most common symptoms? Hot flashes, night sweats, vaginal dryness, and only 1 in 5 women get referred to a menopause specialist. And if they do, that's a long wait time, right? There's not a lot in Chicago. We're trying to change that. I've been really fortunate to work with a bipartisan group of senators on the Hill to introduce legislation to try to get women the answers that they need, to demand that we have federal legislation that says that doctors need to get trained in this. We need to incentivize them to do that, that you shouldn't have to pay through the roof for hormone therapy if that's what you need. Since all women go through this, let's make it an affordable kind of option. And let's fund more research so that we can answer the questions about things like menopausal migraine, right? Not a top priority when you're fighting breast cancer and HIV. So there's a lot of unanswered questions. So Halle Berry is a big advocate for this. And she says that she was shouting, "I'm in menopause," because she's destigmatizing it. And her point is that the shame has to be taken out of menopause. We have to talk about it like it's a very normal part of our lives. How many of you watch Mad Men? Did you see the one where the wife was wearing this tent dress because you were supposed to hide the fact that you were pregnant? And now we have Rihanna doing the Super Bowl, you know, with a big belly, right? I mean, pregnancy used to be viewed the same way menopause is, and we're trying to change that. And we need legislation to do that. And the good news is that we have a very large group of women senators who are trying to advance that. But today we're here to learn a little bit about the basics of menopause, what's going on in our bodies. So we know that as women, we go through hormonal changes at different periods of our life. The first one is puberty. And then we go through changes. That's when we get the onboarding of estrogen and progesterone, when the ovaries start to function. Then we have our reproductive years, our fertile years, when we have our menstrual cycle, and there's this beautiful orchestration of estrogen and progesterone. In pregnancy, our hormone levels peak, and then in postpartum, they drop suddenly. Some of us get depressed because of it. And in perimenopause, peri is that time around the final menstrual period, we usually think, oh, our ovaries are shutting down, so maybe my estrogen level is going like this, right? But I'm going to show you data that says that your estrogen is actually doing this. And you know what the female brain doesn't like? This, right? So in the perimenopause, we don't want to add hormones. We want to shut them off. We want to shut down that ovary so that we have nice, steady, predictable levels of estrogen. That's the simple secret to the perimenopause. And then in the postmenopause, our estrogen and progesterone levels decrease. But this is a normal kind of reproductive transition that we as women go through. Guys don't do this. They have puberty, yep, and then the testosterone gradually kind of goes down. They don't experience this. Because we're females, we do. What are the general ways in which the ovaries, sorry, this is advancing automatically. What are the general ways in which the ovaries can shut down. One is natural, but many women go through induced menopause following surgery or radiation treatment. Women who are BRCA positive, so that's the gene that causes breast cancer, they'll often get their ovaries removed to prevent breast cancer, and this puts them into menopause. We do research on that group of women as well. And the symptoms in the second category are worse than in the natural menopause. So we have premenopause, perimenopause, and postmenopause. Peri means around, so that's the time before and after your final menstrual period. Anybody know when you become menopausal technically?
1 year.
1 year after your last menstrual period, that's right. So it's 12 months without a menstrual period, and then you go back to that final menstrual period, and it's the day after that final menstrual period that technically you're postmenopausal. But you don't know that for 12 months. You know, why not complicate things? So what's happening to your estrogen? Time 0 here is the final menstrual period. -2 means 2 years before. -4 means 4 years before. And this here is estradiol, and this is average. And what do you see? It's pretty steady for about 8 years before the final menstrual period. And then what happens in those 2 years before the final menstrual period? There's this drop. And it continues for another 2 years. And then it reaches this steady state. So when we talk about the symptoms of menopause, the onset of those symptoms corresponds to this change in estrogen, right? So this 2-year time frame. So this is when most women seek help, the perimenopause. Too often we think that we need to think about our health in the postmenopause out here. But the point is that in the field of menopause, we're bringing it earlier on because it's these changes in hormones that precede your final menstrual period that give us a lot of trouble. Remember me saying that hormone levels do this? So my colleague Nanette Santoro measured estrogen every day in a big cohort of women who were in the perimenopause. And I just want to show you how variable your hormones can be. This is a metabolite of estradiol. Day. Look up here. Woo, woo. That's like pregnancy values. And it comes down, comes up, comes. This is not a normal, nice menstrual cycle orchestration. This is variability. And this, ladies, is why we get irritable. It's why we get migraines. It's why we become sad. And the goal is to suppress this variability so that our bodies know what to predict, okay? So when you go to your practitioner, if you're in the perimenopause, those years up to then, we'll talk about how you know if you're in the perimenopause. This is kind of the idea that I want you to have in mind, because unfortunately, your primary care provider won't necessarily know this. They might be working on that assumption that everybody's just declining like this. So you may need to teach your provider, oh, I don't think I need more estrogen. I think I need to suppress my ovaries with oral contraceptives. So this is how we can educate them. How many of you have seen these tests to find out when you're final, well, like where you are in the menopause? Like it's a pee on a stick test. Has anybody seen this? So people are making a lot of money on this. So now that you know this, and if I tell you that test measures that LH, the first hormone, if you take that test on day 20, it will give you a very different value than on day 30. And that's why those tests are invalid. Don't buy them. It makes no sense. People are making a lot of money on this. But because of these, those tests don't work, okay? So how do you know if you're entering perimenopause? Well, let's talk about how do we know our ovaries are shutting down? This actually happens in the late 30s for many women. And what happens is that whatever your normal menstrual period is like, suddenly changes. So let's say you bleed for 4 days, and days 1 and 2 are the heaviest, and then you're done. Okay, and that's your cycle, whatever it is. Suddenly you're bleeding now for 3 days, and it's really heavy, And the next cycle, it's kind of like that again, and then it switches the following cycle, so that whatever was normal for you is no longer what you experience. That's when you're at the very, very beginning of the ovary shutting down. It's called the late reproductive period, technically. And a lot of women experience mood symptoms at that time. Not surprising, the ovaries are shutting down, our brain doesn't like that withdrawal from estrogen. Okay, now, let's say you get your cycle every 28 days regularly, like clockwork. And then suddenly, oh, took me 35 days to get my next cycle. And then the next one was 17 days later. So instead of being every 28 days, it's either shorter or longer. That's when you've entered perimenopause. Okay, when your cycle length changes. So the gold standard criterion for whether you're perimenopausal is not a blood test. We don't measure LH. You can see why. We don't measure estrogen. You can see why. We ask you about your menstrual cycles, and that's the gold standard criteria. That's the early perimenopause. Late perimenopause is when you skip a period. Yeah.
I'm just curious about the menstrual cycle. You said
Yeah.
it can fluctuate a lot. You're seeing that, so maybe it's 18 days, 26.
Yeah.
What if it's just shorter? It's like 20 days.
If-
but it's consistent.
If it's consistently shorter, it could be the onset as well. Yep, so it's a change in the length of the cycle that's reliably different from whatever that length was for you. Great question. Yeah, that's the early perimenopause. And the perimenopause can last as much as 8 years. You want a short one. I really want a short perimenopause if you can. But the treatment for your symptoms in the perimenopause is not hormone therapy. It's suppressing this. So you need to tell your physicians, hey, I think I need an oral contraceptive. Okay, so the median age, the median age of menopause in the final menstrual period is 52.4 years in the United States. So women's life expectancy is about 88 years in the United States. So women are going to spend half of their life either in the perimenopause or in the postmenopause. So we really need to think, what do these changes mean for my health? Not just my brain health, not just my mood, but my heart, my risk for diabetes. It's really important because you have estrogen receptors everywhere. You have estrogen receptors in your lungs, in your skin, in your urogenital system, in your liver, in your brain, all over. That's what I focus on. And so you can get these changes that occur with the loss of estrogen in all of these bodily symptoms. Now, what are the symptoms? What are our most common symptoms? What do you think of when you think of menopause? Hot flashes is the number one. What else? Brain fog.
Disrupted sleep.
Disrupted sleep. Yep. What else? Yep. Irritability, sadness. How many of you would have thought shoulder pain? Yeah, it's the number one symptom. So, second symptom is hot flashes. The third one is forgetfulness, then sleep, and then heart palpitations, very common. Urine leakage and vaginal dryness. Now, vaginal dryness increases dramatically. These are women aged 40 to 55. Vaginal dryness starts in the 60s. It's important to prevent that. Vaginal estrogens do that. So here you have all women in the early. So these are women whose cycles are now irregular. And you can see actually that forgetfulness is more common than hot flashes. And then what happens in the postmenopause and in the late perimenopause? This is when the hot flashes become more prominent, right? So your symptoms will change over time, but critically, was your experience with pregnancy the same as your best friend's? Was your experience with your menstrual cycle the same as your best friend's? No. Just like that, your experience of menopause will differ. It's actually quite similar to your mother's. So if you remember that, this is going to show you the different menopause experiences. So I'm going to get really researchy just to normalize how important it is to recognize that just because we don't experience something in menopause doesn't mean that our best friend experiences something different. 27% of us will have low hot flashes, low sleep problems, depression, no, anxiety, pain. So for about 27% of us, or 29% of us, it's not a problem. And those individuals can have a difficult time understanding why the rest of us have some problems. So most women, 40% of women, have mildish symptoms. They don't have terrible symptoms of menopause, so we don't want to pathologize it, but when they have it, it's not necessarily the hot flashes. What's bothering them? What are these two bars? Sleep. In fact, sleep affects quality of life more than menopause, more than the vasomotor symptoms do. So if you're experiencing sleep problems, totally normal, and it's menopause related. Okay, 14% of us have a really tough time with everything. 11% of us don't have problems with our mood, but have everything else. And then there's about 7% of us who only have problems with our mood. And the problems are severe. Okay, so there's not one menopause. Okay, so you need to treat your own symptoms, and we'll talk about the main symptoms, based on whatever's bothering you. I will say that research is suggesting that even in the late 30s and early 40s, when your cycles are changing and they're no longer the cycles that you typically experience, these are the complaints that women have. And the number one is brain fog. 60% of women, 57% say they're irritable. And the one message I have to women is be kind to yourself, right? Have you heard a guy apologize for being hangry? Right? Anyway. Yeah. Okay, so be kind to yourself. This is biology here, and it's that fluctuation in estradiol that makes us irritable, and we have brain imaging studies that tell us what part of the brain is no longer acting like a symphony. The part of our brain that can no longer regulate our emotions. It doesn't mean that you shouldn't be asking questions about it, but I want you to consider this something biological and be kind to yourself if you do. Yeah, question about it.
So related to the forgetfulness and irritability and brain fog and everything, it seems interesting that this period is also the period where most of us are probably the busiest in our life. We're sort of in this bend of life where like, I think all of us are like running around and dropping people off and picking somebody up, and this is all happening at the same time.
Yes.
So how much of it is actually a function of like what we're doing on a daily basis and what's going on biologically?
Perfect question. And it's one we're all asking. Is it menopause or is it just my life being stressful? So here's the conceptual idea. That same level of stress, if you were premenopausal, would not trigger you to be irritable. It's the fact that your hormonal milieu is changing that makes you more irritable. How do we know this? Thankfully, ladies, you can cite research. You don't have to say it's your opinion. People actually measured estrogen, like that other study, every day in women, and found the women who were sensitive to variability in estrogen, meaning their mood ratings changed when their estrogen levels changed. And if they had a significant life stressor, their irritability was threefold higher than other women. Okay, it's also the case that my personal sensitivity to fluctuations in estrogen is not your sensitivity. That's an individual difference factor. So some of us with daughters, may predict, where they are in their cycle, and other daughters, you don't, right? So it's individual differences in your sensitivity, mood-wise, are the norm, right? But we do know that life stressors superimposed on those fluctuations are what trigger this irritability. There's science behind it. So again, the idea is to suppress that variability with an oral contraceptive, so that when that life stressor comes, you can handle it. That's the general idea. Other questions? Yeah.
What that 29% is doing, the ones that have dramatically lower symptoms.
They seem to have won the genetic lottery. So we know that there are genes that code for this type of neuron in the heat regulation area of the brain. It's called a candy neuron. You know, it's kind of cute, candy neuron. And genes predict the function of those neurons. And depending on your genotype, you will have either worse hot flashes or easier hot flashes, which is why your hot flashes are similar to your mother's. And then in work that we're doing, we actually think those candy neurons are responsible for some of the sleep problems that we experience at menopause and beyond. So part of it's genetic. Yeah. That being said, having more social support for when we do have those life stressors, having means of adapting to those life stressors, stress release, yoga, exercise can help us to mitigate against those lifelong stressors. But again, it's not all under your control through those lifestyle interventions, because again, it's superimposed on that variability. Is that clear? Okay, great. 59% of women in their late 30s and early 40s expected the changes of menopause to happen in their 50s. So there's this mismatch between what the data is showing and what women are experiencing. In other words, if you're in your late 30s or early 40s and you feel this brain fog or irritability, don't rule out menopause just because your practitioner says it probably isn't menopause, because your practitioner's had less than an hour of training in menopause. Research shows that menopause does affect women's work performance, not for the majority of women, because the majority of women have low symptoms. But for those women who do have symptoms, they complain of tiredness because of the sleep problems, forgetfulness, feeling depressed, poor concentration, and then low confidence because their work performance at the time in their life where they're just getting that peak job is suboptimal, and it's very frustrating for women. So there's a whole movement of menopause workplace policies starting in the United Kingdom. It's all over Europe. We're slow to adopt them in the United States, but we are slowly but surely doing it. So let's talk hot flashes. 80% of women experience a hot flash. So that's those 27% experience very low levels of it, but they still experience some. On average, what is that number? 7.4 years? What? 50% of women experience them for more than 7.4 years. And if you're a Black woman, it's 10 years on average. And if you're Latina, it's 9. So there are racial and ethnic differences. And these peak in the first 2 years of the postmenopause. Now, sleep disturbance is 40 to 60% of women, but I'll show you that unfortunately, it continues into the postmenopause. And the phenomenon is not so much difficulty falling asleep. It's staying, I didn't even need to tell you. You knew, it's staying awake. So you want to be sleeping, but you're not sleeping because suddenly you're up. And then what do you do when you wake up? You get stressed. We're female, so we ruminate. And then we think, oh, I'm never gonna get to sleep. I'm not gonna wake up in time. I'm gonna miss the driving the kids here, and I've got that big presentation. We catastrophize. So when I talk about sleep, I'm going to be talking about the evidence-based approach for those problems, and they work. So we can deal with that too, because they do continue into the menopause. So I showed you that many women experience mood problems, hot flashes, and sleep, right? That one bar that was missing from that study was cognition. And now I'm going to show you that your brain fog is related to all of those. You don't need a menopause researcher to tell you that if you haven't slept well yesterday, your brain is not good, right? You don't need to pay me to do that study. You know that. You also know that if your mood's a little low, you're depressed, you can't pay attention as well, right? So your cognitive function is gonna be impaired. And then one of the contributions that our team has made is that your hot flashes are making you forgetful. So I'll show you some of that. So I won't ask how many of you have experienced a hot flash, but this is what they're like. So in Western women, they generally start here, and it's this sudden 0 to 100, unbidden feeling of heat. And it kind of rises through the neck and it goes to the top of the head. Women who wear scarves, it actually starts here. Okay, and it lasts on average for 1 to 5 minutes, but then it dissipates. So it's sudden. Some women feel it all over their body, and we're going to talk about how severe they are and how you know if they're mild, moderate, or severe. Episodes vary. Some women have 1 a week, and I'll show you our winner, a woman who had 51 in 1 day. So when they're mild is usually when you first start to experience them, and then when they go away, because they do go away for most women, they go away. And then they're mild and you're like, ooh, I'm hot. Oh, I'm hot. And that's what it's like. Moderate is, ooh, I'm hot, oh, and I'm sweating. Okay, so it's when the sweat is there, but you're able to continue your activity. Severe is, I'm feeling this heat, I'm sweating, and I can't function. So that happened to me on a treadmill once. I was like, oh my God, I gotta stop. I don't know what's just happened, but I'm hot all of a sudden and I have to get off this treadmill. So it was so bad that I actually had to get off the treadmill. I'm lucky I didn't have bad ones, but you have to stop what you're doing. Now, here's, we measure hot flashes objectively in our research studies. We have these little electrodes that we put in women's sternum. And then when you sweat, there's a little change in electrical activity on the surface of your skin. But that's all to say that these are objective. You don't have to tell us how many hot flashes you're having. We know when you're having them. So if I want to know how many hot flashes you're having when you're sleeping, how are you going to tell me? Right? Yeah, I'd have to wake you up, right? And you'd have to like get up to tell me. So this is that 0. You go from nothing to something here. See this? Every one of these is a hot flash. This is a woman having 37 hot flashes in 24 hours. So they come on suddenly and then they dissipate. Some women, you can set your watch to them. Now, 33% of women have severe hot flashes more than 10 years after the final menstrual period. It doesn't mean that they have them every day, but they experience them. So that's all to say that while you have that final menstrual period, and that's when you're postmenopausal, the symptoms can continue after that time period. Okay, and it's really important that we not just let those symptoms be. My hot flashes aren't your hot flashes. I bet most of us think we don't have hot flashes and then we enter menopause and we do, right? That's what we think. So what does the data show? Well, that's this group here. Okay, 29% of women have that. So here's the final menstrual period, nothing, nothing, nothing. Ooh, here we go. Here's that lucky, ooh, had a little blip, nothing too bad. Those are the lucky ones. Look at these women. 25% of women. When are they having their hot flashes? This is the final menstrual period. Premenopausally. So if you go to somebody, to a physician, and they say, oh, you're having hot flashes, you must be menopausal, they're wrong. Because it turns out that up to 43% of women have their hot flashes premenopausally. So you can't use hot flashes to diagnose how close in time you are to your final menstrual period. Okay? Oral contraceptives are a really good option for these hot flashes too. But that's all to say that the experience of hot flashes over time differs from one woman to another. So different women need different treatments. Hormone therapy, menopausal hormone therapy, which is estrogen and progesterone. You need the progesterone if you have a uterus because estrogen alone will cause cancer of the uterus, endometrial cancer. And if you take progesterone, that goes away. Because estrogen builds up the lining of the uterus and progesterone takes that away. Okay, so that's why you need it, so you must take it. And hormone therapy is the best option. Especially before age 60 or within 10 years of your final menstrual period. So this is gold standard. Everybody agrees this is the best. How many of you saw a hot flash commercial on the Super Bowl? Yeah, that went over like a lead balloon with the guys, but at any rate, that's because there's a new, very, very, very effective non-hormonal treatment called Veoza. Has no estrogen in it, and it takes hot flashes away within a week. It's a really good treatment. So that is, the clinical effect is apparent within a week. It's called Veoza. So that's in FDA. It's called, Veoza is what it will be marketed to you as. The generic name is fezolinetant. Low dose paroxetine is an antidepressant. It'll take away one objective hot flash a day. I don't recommend it. I don't think it has a very big clinical effect. But off-label antidepressants can work, and then there's some other options that some women will take, especially if they're breast cancer survivors. How many of you have heard hormone therapy causes breast cancer? Right? And we don't want breast cancer. So we need to understand what is the risk of breast cancer if we do take hormone therapy, okay? What is risk? How do I quantify risk? Because if you can't quantify risk, how do you know if it's a safe option for you? Well, let's quantify risk. Let's learn a little bit about how medical societies quantify risk. Okay, so I want you to picture an arena that holds 10,000 people. Got it? Okay, so arena 1 has 10,000 midlife women all on hormone therapy. Okay, and they're in that arena for a year. Got it? Arena 2, similar women, 10,000 of them. They stay in that arena for 1 year. None of them are on hormone therapy. Okay, now I'm going to talk about how many of them get breast cancer in each arena. Okay. Okay, here's breast cancer. If you're on estrogen plus progesterone, 6 more women in the arena where everybody took hormone therapy will get it. 6 out of those 10,000 more compared to this arena. That's the risk. Yep.
But that's only the risk on the hormone therapy. What about like your standard risk of getting breast cancer?
Yeah, okay, so it's 2.7 women per 10,000 versus 3.2 if it's a percentage. But they quantify it as the number of women. So it would be, here the breast cancer would be 6 women in this group and about 2 in the other. Okay, so the risk is very low. What about estrogen alone? What happened with estrogen alone? It was decreased. So estrogen alone, and it had to do with the formulation of estrogen. And this is the biggest, best study. This is more than 10,000 women. Okay, so this is a really good study. Okay, so that's the breast cancer risk. So that's the risk you're considering when you're deciding whether to treat your hot flashes. Do you want to take the risk of having those 6 cases out of those 10,000 women more? Yep.
How long, the people that were on the HRT, how long had they?
5 years.
5 years.
5 years. Yeah. Now, if they're older, if you're 60 to 70, that risk increases to about 9. But that's the risk. So you have to weigh the fear of breast cancer against the benefits that you would have if you treated your hot flashes, if your sleep got better, if your quality of life got better, etc. It's not a non-zero risk. There is a risk, and anybody who tells you there's no risk is wrong. That's not true. There is a risk with estrogen plus progesterone in 6 more people. Now, yeah.
Your body is already creating estrogen and progesterone,
Yes.
so why is this worse? Like what changes in your body that when you have to replace it, it makes it worse?
It's the duration of exposure to estrogen. So the longer our bodies are exposed to estrogen, the higher our risk for breast cancer. So it's adding on more time on estrogen. I have a colleague who has a very interesting perspective on this, which is that evolutionarily, we were pregnant all the time. Our bodies weren't used to seeing this estrogen for this long, right? So we didn't, if you will, evolve to fight it. And what it does is it doesn't cause de novo cancers. It takes those, if you will, pre-breast cancer conditions and turns them into something clinically apparent. It's not, it doesn't start at de novo, in other words. Yeah.
Earlier, you made the comment that if you're taking estrogen, you want to take progesterone to reduce your risk of uterine cancer. But then this one shows that it increases your risk of breast cancer. What's the balance of like, if you're increasing or decreasing the risk of two different cancers, which one's like the better option? Or like,
Yeah, so you must take the progesterone. It's like threefold increased risk of endometrial cancer without progesterone. You must take a progesterone. You just have to do it. But the good news is, there's a fancy new drug called Duovy that I recommend to a lot of women with, which is estrogen paired with a SERM, a selective estrogen receptor modulator. So then how many of you have heard tamoxifen or loxapine, right? Those are breast cancer drugs. They're anti-estrogen in some tissues. So this formulation gets rid of the progesterone and pairs the estrogen with a SERM. And that's really good for the breast. It actually seems to regress breast tumors. That's called Duovy. But here's the other thing though. Progesterone makes us sleepy. So many of us want progesterone and we want to take it at night. So you have to individualize it. The sleep's a problem, you gotta individualize it. Okay, the other thing that you're gonna hear, sorry.
So you said with estrogen for age 60 and over, the risk is higher.
Yeah.
Do you think that is so because of the estrogen, or as women get older, the risk of breast cancer
It's because of the estrogen, because you have the placebo group to measure the age-related risk that you would get naturally. So it's a risk above and beyond that. So we really need solutions for those women who continue to have hot flashes into their 60s and 70s, and I see them in my research studies all the time. We need other alternatives. It's not a non-zero risk. There is a risk, but that is the magnitude. The other chatter,
Is
sorry.
it only, so we just talked about breast cancer, but then your stroke, heart disease,
Yep.
like all of
Right,
those.
exactly. So all of these are
I thought it was protective for heart. Estrogen.
estrogen alone. Okay, but let's think about the protective for heart. Let's take the same critical thinking and apply it to the benefit. 11 fewer women out of that 10,000 are gonna have a heart attack. So it doesn't really work, does it, to prevent heart disease? No. It's not a solution for heart, but you're gonna hear it marketed as such. You're gonna hear people tell you, you should be on hormones for life because it's gonna decrease your risk of heart disease and dementia and the like. This is how much 11 women out of those 10,000. That's not like exercise, it's not like eating right? So don't buy the hype. And people make a lot of money out of selling these hormones to you. You need it if you have hot flashes, don't get me wrong. I think you need it if you have hot flashes, and I'll show you some data to suggest that. But otherwise, it's not an anti-aging, no matter what you hear online. Right? And now you know why, don't you? You don't have to take my opinion, I just showed you the data. Okay, yeah.
For the study of the women on oral estrogen?
Yes. It's oral estrogen, so yeah, transdermal does not have this effect on deep vein thrombosis or pulmonary embolism or stroke. So if you take it by a patch or a gel, you can get rid of those, but it still has the small risk of breast cancer, and the risk of heart disease. We don't really know with transdermal as much. Seems to be potentially protective. And I'll also say that this is with the most toxic form of progesterone, which is medroxyprogesterone acetate, which most women don't use. And micronized progesterone probably lowers this risk compared to this more toxic form. So the general idea is that it's quite safe. but the risk is not zero. It's there.
I keep hearing that all-cause mortality goes down with
It does.
HRT.
It all-cause mortality goes down by a factor of, let me think, I think you'd have to treat 2,000 women to prevent one case of early death. That's another way to think about how to translate this epidemiology, and that comes from the 18-year follow-up data. Okay, and I don't have that picture here. That's reassuring news for women. When your risk of dying when you're on hormone therapy is lower, it's reassuring that it's safe. But does it mean it's an anti-death drug? No. Because you need to treat thousands of women to prevent that one case of early mortality. Yeah, not like exercise. So, it's important to be informed about the risks. So if you're somebody considering it and you go into a doctor and they say, oh, I can't prescribe that to you, it causes breast cancer, you know what the data show, right? Talk about sleep. This is waking up during the night. 30% of us. And if we have our ovaries removed, it's 50% of us. So it continues. We wake up when we have a hot flash. This is when we measure those hot flashes with our monitors, and then we use wearable devices to measure when we wake up. We wake up 78% of the time when we have a hot flash. But your sleep problems are actually not due entirely to that, because 2/3 of the time you spend awake at night have nothing to do with hot flashes. Something else. So this is the solution. It's called cognitive behavioral therapy for insomnia. Have any of you heard of it? CBTI? Okay. This is the gold standard. It teaches your brain to sleep. There's a reason I asked you, what do you do when you wake up? So what CBTI does is it teaches you not to do that, and it teaches you how to fall right back to sleep. So it's like a habit. You can Google CBTI and VA, and you can get a free CBTI program, and you can take it at home. It is recommended by the American Academy for Sleep Medicine. It's how we treat this. What about estrogen patches? They do seem to help in the perimenopause, not necessarily in the late perimenopause, even if women don't have hot flashes. So what that tells us is that the changes in estrogen have something to do with it, and progesterone at night can help many women fall asleep. So if you get hormone therapy, take your progesterone at night. It works on the same part of the brain that benzos do. You don't want to take sleep medications. They don't restore quality sleep. If you're going through bereavement or you have to get through something, then fine. But it's not a long-term solution. You have to do the hard work and kind of train your brain. CBTI, mood. 45 to 70% of women get depressed versus 25 to 30% of premenopausal women. And this is related to the menopause. This is how many of us at any given time will have clinical depression. So 5% if we're premenopausal, 9% if we're peri, and 9.8% if we're post. And this is controlling for age. So there is an association between depression and menopause. And even mild symptoms are going to affect our ability to perform at work. So let's talk about brain fog, or what I call cognition. So this is something that I and my colleague Nicole Jaff wrote. It's here's just Google IMS and brain fog, and you'll get this patient handout. And it's available in multiple languages because this was through the International Menopause Society for World Menopause Day. Yay, my favorite holiday. All right. This is about brain fog and memory difficulties. So this is really helpful to hand out to your friends, because you know what the nice thing about it is? You hand somebody this thing and it's about brain fog at menopause. And what signal does that send? It's perfectly normal. It's normal. You're not dementing. And we talk about the fact that you're not dementing. So the cognitive ability that changes as we transition through the menopause is verbal memory. That's what I'm doing right now. I'm talking at you. I'm speaking in words. I might tell you a story. You have to learn that. And maybe, just maybe 2 weeks from now, when you're talking to your cousin, you're going to try to recall what I said back to her. The terrible thing about menopause is that's the ability that changes on average in women. We measure this with a grocery list. So we have a difficult time doing that, and hot flashes play a role. This is one of our discoveries. So the more hot flashes we measure with those monitors, the more Alzheimer's disease pathology we can measure in blood, the more altered our brain function, and the more stroke-like lesions we have. And I envision that in 10 years, we're going to treat hot flashes the way we treat blood pressure. We're going to say that if you have moderate to severe hot flashes, you have to treat them to protect your brain and your heart. That's where I see this field going. So you get the early message. Treat them, avoid them for those, 7 years. If they're moderate to severe, not all of you need that. Many of you will fly right through. You don't need it. But if you're one of the women who's having moderate to severe hot flashes, especially year after year, you're going to want to treat them because it's associated with these brain problems. And we want the healthiest brain we can. If you've had your ovaries removed before age 48, that increases the risk of Alzheimer's disease by 70%. But treating with hormone therapy takes that risk away. If you don't have hot flashes, hormone therapy gives your brain no benefit. You're going to be hearing chatter online about that. We have 4 beautiful clinical trials that show it doesn't work at all for your memory if you don't have hot flashes. So you need another solution. If you do have hot flashes, we don't have the randomized trial, but theoretically it should work. Will brain fog lead to dementia? Nope. Okay. Can I prevent dementia? Yes. That's the good news. What % of your risk of dementia do you think you have control over? 10%? 20? 30? 65? Yay! That's good news for women. There's some things we can't control. The fact that we're female, we don't want to control that. We like that. Age, genetics, but there's a lot we can do. And this is the final kind of take-home message. Your heart health is your brain health. You need to make sure, especially, that you control hypertension. Because if you don't control hypertension, you get these little stroke-like lesions in the brain. So you want your cholesterol levels to be healthy. Really important. So you want to bring the healthiest brain you can into your 60s and 70s so that if and when the pathology of Alzheimer's disease comes, your brain says, nope, I'm too strong for that. I've got me a good brain. Think about it the same way you think about your heart, right? You build up really good muscle mass, you build up really good cardiovascular function, you want to build up good brain function. Exercise is important. You want to maintain an exercise regimen of at least 150 minutes of moderate intensity aerobic physical activity weekly. It does not have to be all in a row. It can be 10 minutes here, 10 minutes there, but the goal is 150 minutes. Increase in body weight is perfectly normal. At this time in life, it's driven largely by age. But what menopause does is it shifts our fat so that we have that little donut. Okay, so the total weight doesn't change, but our body fat distribution does. And the thing that we do is we start lifting weights. So we can't do just that aerobic exercise that we used to. We have to do weightlifting because that will change the distribution of fat. So that's the solution. Don't work out more. Don't, do that aerobic. You want to lift more weights. So weight management is really important. If you smoke, don't. Do what we're doing right now. One of the best things about living in Hinsdale is the women in Hinsdale and the ability to have conversations. And when you have a conversation, if I'm talking to Susan, I'm paying attention to Susan, I'm listening to Susan, I'm remembering what's happening in Susan's life, I'm bringing it into the conversation. I'm trying to think about the best way of having this conversation, maybe trying to make her laugh. My brain is on fuego, right? I am on. So conversations and social activity is surprisingly a key factor for brain health. Social isolation is dire for your brain. You want engagement. You know what engagement isn't?
Yeah, right, our poor kids.
Right? I'm not paying attention. I'm a passive recipient. So you want to really make a point of engaging socially. It's really, really, really good for your brain, and it's really, really good for your heart. So stay connected is evidence-based. Conversations are evidence-based. And then you want to exercise your brain, like coming out in the rain and listening to some professor talk about menopause. You know, that's really good for your brain because you're learning new stuff, right? Can't be easy. It can't be, you know, what you do really well. You have to do something hard. Some of us dance and sing very well. I don't. So for me, that would be a cognitive activity that would build my brain and shame my daughter. But nonetheless, you know, we would want to do it. So these are how we keep our brain healthy. There's a lot we can do to keep our brains healthy. Sleep is really important. So you want that CBTI. Best resources. I'm biased because I'm on the board of trustees, but the International Menopause Society has great videos for the consumer. I just say IMS, International Menopause Society. Canada has this beautiful resource, the Women's Brain Health Initiative, really great user-friendly digestion, if you will, of research studies, Lynn Poslin's. The Menopause Society is really, really good as well. And the book that I suggested that the library get is in the back. That's by the executive director of the Menopause Society, Dr. Stephanie Fabian. That's super good. And then you have a neighbor in menopause, right? So I do a lot of, you know, oh, just text Pauline, see, you know, see what she says. Because it's really hard to get a provider. And I will share my provider's name, my preferred provider, if you want a really good menopause practitioner. Her name is Monica Christmas, and she's at the University of Chicago.